Hello and welcome to my online training on community clozapine titration. The learning objectives for today are firstly, to understand the indication to prescribe clozapine and the clozapine mechanism of action. Then we'll look at clozapine common and serious adverse effects and how to manage these in clinical practice. Thirdly, we will discuss the principles and monitoring of clozapine community titration. And finally, I've included a short revision on the National Early Warning Scale and its applicability to clozapine. So, moving on, clozapine is an atypical antipsychotic licensed for treatment-resistant schizophrenia. It is licensed only for use in service users whose schizophrenia has not responded to or who are intolerant of conventional antipsychotic drugs. Two other first-line atypical antipsychotics should be tried before clozapine, one of which should be olanzapine. And it was the first antipsychotic to be recognized as atypical, causing few, if any, extrapyramidal side effects, not being a cause of tardive dyskinesia, and not to elevate prolactin. Clozapine pharmacokinetics, or what the body does to the drug. We're going to look at the absorption, distribution, and metabolism of clozapine on this slide. Absorption of orally administered clozapine is 90 to 95%. Neither the rate nor the extent of absorption is influenced by food. Clozapine is subject to moderate first-pass metabolism by the liver, which results in absolute bioavailability of between 50 to 60% of clozapine in the plasma. In steady-state conditions, when given twice daily, peak blood levels occur on an average at 2 hours. So now we're going to look at clozapine pharmacokinetics at the elimination of it. This plasma concentration over time graph is from a comparative study of two competitor brands of clozapine giving single doses of clozapine 100 milligrams. After single doses of clozapine 100 milligrams in this comparative study, the mean plasma half-life, which is the time it takes for the drug to be half the concentration in the plasma, was about 7 hours plus or minus 2 hours. In the literature, clozapine has a mean terminal half-life of about 12 hours with a range between 6 to 26 hours after a single dose. The half-life is known to increase to a mean of about 14 hours when steady-state conditions are reached by administering daily doses for at least 7 days. On this slide, we can see in the clozapine pharmacokinetics once clozapine has reached steady state. We can see on this plasma concentration over time graph on a comparison study of clozapine of 400 milligrams once daily versus 200 milligrams twice daily, that when given twice daily, the plasma concentration peak and trough levels are within the therapeutic window, whereas when given once daily, both the peak and the trough fall outside of the therapeutic window. Clozapine plasma levels should be within a therapeutic window of between 0.35 milligrams per liter to 0.5 milligrams per liter. Plasma levels above 0.6 milligrams per liter increase risk of seizures. Okay, so now let's look at pharmacodynamics. Clozapine targets 5 primary neurotransmitters. In addition to the intended dopamine and serotonin sites of action, clozapine is a potent antagonist at the alpha-adrenergic, histaminergic, and muscarinic receptors. The affinity to these 5 neurotransmitter sites provides an indication to the likely side effects seen in clozapine titration. So firstly, serotonin receptors, they antagonize or block the serotonin subunit receptor 5-HT2A. The full function of this receptor subgroup is unknown, however it is thought to be antipsychotic, anti-Parkinsonian, and possibly procognitive. Secondly, the muscarinic receptors are located at many places in the body. M3 receptors are located in the smooth muscles of the blood vessels, as well as in the lungs and typically cause contraction of smooth muscle. The MC receptors are also located in many glands, which to help stimulate secretion in, for example, the salivary glands, as well as other glands in the body. Histamine receptors play an important role in the body and are involved in many physiological functions. It is involved in local immune response, it regulates physiological function in the gut, and it acts as a neurotransmitter for the brain and spinal cord. Histamine is involved in the inflammatory response, and it has a central role as a mediator of itching. In the central nervous system, histamine promotes the sleep-wake cycle, promoting wakefulness. It regulates body temperature, nociception, endocrine homeostasis, and it regulates appetite. The alpha adrenergic receptors, which leads to on activation, it leads to vasoconstriction. Therefore, an alpha adrenergic antagonist is likely to result in vasodilation. Adrenergic antagonists have an inhibitory or opposing effect on the receptors in the adrenergic system. The adrenergic system modulates the fight or flight response. Since this response, which is mostly seen as an increase in blood pressure, administration of an adrenergic antagonist, it will result in a decrease in blood pressure, which is controlled by both the heart rate and vascular tone. So moving on to the dopamine receptor, similarly to other atypical antipsychotics, when clozapine binds to dopamine receptors, it rapidly dissociates from the receptor site before dopaminergic side effects, such as dystonia and tardive dyskinesia, can occur, but long enough to treat the positive symptoms of schizophrenia. Clozapine antagonizes dopaminergic receptors, which by order of binding of affinity are D4, D1, D2, and then D3. There's strong evidence that blocking dopamine 2 receptors correlates with antipsychotic effect. However, due to the preference for D4 and D1, antipsychotic effects through D2 receptors are usually only seen at higher doses. Myoclonus is a sudden muscle spasm. The movement is involuntary and can't be stopped or controlled. It may precede a seizure, and if this is the case, it's advised to reduce the dose. It's advised to consider starting an anticonvulsant to stop progression to seizures, with valproate being the first choice. Clozapine is associated with an increased risk of seizures, and a common practice is to begin a prophylactic anticonvulsant at doses above 600 milligrams, but the rationale for this has been debated. The risk of seizures increases in a linear curve over the dose range, but there's no universally accepted threshold or plasma level. However, what is established is that clozapine of equal to or more than 1.3 milligrams per litre are associated with a very high substantial risk of seizures. They are usually related to dose, plasma level, and rapid dose escalation. After a seizure, withhold the clozapine for a day and then restart at half the dose, and as before with myoclonus, give an anticonvulsant such as valproate. Weight gain. The mechanism of weight gain and increased incidence of diabetes is unknown. However, it may be due to insulin regulation being impaired by blocking pancreatic muscarinic receptors. Weekly weight for the first 6 weeks, BMI, and waist circumference at baseline and then 3 months are indicated. Hypersalivation is socially embarrassing and can have a negative impact on quality of life and has been implicated as a factor contributing to aspirational pneumonia. The pharmacological mechanism is unclear. However, muscarinic agonism and alpha-2 adrenergic antagonism has been suggested. It's advised to consider hyoscine hydrobromide 300 micrograms 3 times a day. Sedation. Sedation is an antihistaminergic effect. It's advised to give a smaller dose in the morning and reduce the dose or slow the titration. Constipation. We'll talk more about constipation on the next slide. However, in essence, advise patients of risk. Screen regularly using the Bristol stool chart and encourage the patient to have regular fibre, nutrition, and exercise. Bulk-forming laxatives are first line, with low threshold for osmotic and stimulant laxatives. Clozapine antagonizes M3 receptors, which has an anticholinergic effect. Clozapine also antagonizes the H1 receptor. Constipation is a common side effect of clozapine treatment, with the prevalence being more than 30%, which is 3 times more than that seen with other antipsychotics. The mechanism of action is not completely understood, but it is thought to be a combination of the drug's anticholinergic and antihistaminergic properties. Additionally, clozapine-induced sedation can result in a sedentary lifestyle, which in itself is a risk factor of constipation. Clozapine causes constipation by slowing transit times through the gut, which means times can be 4 times longer than normal. Gastric hypomotility can lead to sepsis, peritonitis, renal failure, and bowel perforation. There are some established risk factors associated with developing clozapine-induced constipation, which are increasing age, female sex, being prescribed anticholinergic medication, higher doses of clozapine, hypercalcemia, gastrointestinal disease, obesity, diaphoresis, low fibrous diet, poor bowel habits, dehydration in diabetes, hypothyroidism, Parkinson's disease, and MS. Hypotension. Clozapine can cause hypotension, which manifests as dizziness on standing. The cause is reduced vascular tone stemming from blockade of alpha-adrenergic adrenoreceptors on blood vessels. Clozapine has markedly higher affinity on adrenoreceptor than dopamine D2 receptors. Postural hypotension is a feature of the early stages of treatment and usually shows tolerance over several weeks. In terms of advice the patient to take time standing up. Advise increased fluid intake up to 2 liters daily. Reduce dose or slow down rate of increase, and if severe, consider medications such as moclopramide or fludrocortisone. Moving on to pyrexia and fever. Initiation of clozapine is associated with benign and transient pyrexia in 10 to 50% of patients. However, pyrexia in patients taking clozapine should always be investigated, as it can be associated with neutropenia, agranulocytosis, myocarditis, and neuroleptic malignant syndrome. If the temperature is more than 38 Celsius, examine the patient for signs of infection, check for blood count, C-reactive protein, troponin, and creatinine kinase, and exclude NMS. Give paracetamol and slow the titration or temporarily discontinue. In hypertension, monitor the patient closely, increase rate of dose more slowly if necessary. In tachycardia, clozapine can increase the heart rate in normal physiology. The heart pacemaker is inhibited by the vagus nerve and accelerated by sympathetic nerve activity. Clozapine causes tachycardia by blocking the vagal brake whilst boosting the sympathetic accelerator. Clozapine-elicited tachycardia occurs in about 25% of patients during dose titration. Tachycardia is related to the speed of titration. In most patients, tachycardia shows tolerance over a period of weeks but may persist in some. Clozapine-induced tachycardia is very common for patients without signs of myocarditis. Clozapine should be stopped if tachycardia in presence of fever or chest pain, but can be managed by monitoring clozapine levels, dose modification, and daily observation. If symptomatic, there's evidence to rate control with beta blockers such as bisoprolol. On this slide, we're going to look at the serious side effect of neutropenia and agranulocytosis. Neutropenia, which is a lack or a deficiency of neutrophils, are abundant white blood cells that provide the first line of defense in the body against invading microbes via something called phagocytosis of pathogens. Neutropenia is defined as an absolute neutrophil count of below 1.5 times 10 to the 9 liters. Severe neutropenia with an absolute neutrophil count is 0.5 times 10 to the 9 liters, and it's known as agranulocytosis. Neutropenia presents as either an incidental finding on a blood routine test or as a clinical emergency in the case of something called neutropenic sepsis. Neutropenic sepsis includes fever, rigors, shortness of breath, confusion, hypotension, tachycardia, or lower urine output. Myocarditis, the inflammation of heart muscle, may be caused by a variety of conditions. It is an established complication of clozapine treatment, and often 80% of cases occur within the first month of starting treatment. Most often, symptoms are non-specific, such as feeling unwell, flu-like, or fever without rigors. Chest pain is present in a third of cases and presents as heavy, crushing, with radiation to the arm or jaw, or atypically with chest pain or pleuristic pain, which is sharp, worse on breathing deeply or leaning forward. It often presents as fever, tachycardia, with an increased respiratory rate of more than 20 breaths per minute, a decreased systolic blood pressure of less than 100, and rises in the CRP above 100 milligrams per litre, or double the upper limit of normal in the troponin have also been seen. If either the troponin double upper limits or CRP above 100 milligrams per litre are seen, discontinue clozapine and consult a cardiologist. Now let's look at the serious side effects of venous thromboembolism. A thrombus is a formation of a solid mass of blood products within the circulatory system. An emboli is a blockage of a blood vessel by a solid, liquid, or gas collection distant from its site of origin. The term venothromboembolism comprises deep vein thrombosis, DVT, mostly found in the pelvic area or deep leg veins, and the movement of the clot to the lungs when it is known as a pulmonary embolism or PE. As with all antipsychotic drugs, the cause of thromboembolism is probably multifactorial. However, sedation may lead to reduction in movement and consequently venous stasis. There is a suggested association between clozapine and thromboembolism. It's more likely to occur in the first 3 months of treatment, but can occur at any time. This may be due to clozapine's effects on the antiphospholipid antibodies and platelet aggregation via 5-HT2A. A diagnosis of DVT should be considered if a patient with unilateral calf swelling and pain. The clinical assessment should be based around calculating the revised Wells score. At this point, it would be expected for the patient to have a new score that would warrant contact with either a member of the on-call medical team or for the patient to be taken to A&E. Now we're going to look at clozapine principles of suitability, baseline observations, and monitoring during community clozapine titration. Now we're going to look at suitability and contraindications of clozapine. Suitability for initiation. All of the answers to this question should be yes. Versus contraindications against initiation. All of the answers to this question should be no. Is it possible to see the patient daily? Has the patient understood the need for regular physical monitoring and blood tests? Has the patient understood possible adverse effects and what to do about them? Will they be likely to seek out of hours support in the event of a serious adverse reaction? Does the patient likely to adhere to oral medication? And in contraindications, is there any history of significant cardiac disease? Is the patient unreliable or chaotic in their lifestyle, as this may affect medication adherence? Is there significant cocaine or alcohol abuse? Has the patient previously had a significant adverse effect on a clozapine titration? And does the patient have a history of seizures? On this slide, we're going to talk briefly about the clozapine initial physical workup prior to titration. There should be a physical examination which should include a full blood count, liver function tests, urea and electrolytes, lipids, glucose, fasting plasma glucose, a troponin and a C-reactive protein should all be considered as baseline for further tests. An ECG should be performed for evidence of past myocardial infarction or ventricular abnormality. Blood monitoring, service registration, perform white blood count and differential count before starting clozapine. Further bloods to be continued weekly for the first 18 weeks and then 2 weekly for the remainder of that year. 14 days for the AWP standard inpatient versus the AWP community charts. Again, it's important to note that many patients need either a slower or faster titration rate depending on patient tolerability. Clozapine doses are commenced at 12.5 milligrams 1 to 2 times a day for day 1. Then on day 2 at doses of between 25 to 50 milligrams. Then increased, if tolerated, in steps of 25 to 50 milligrams daily. Doses can be increased gradually over the next 14 to 21 days. The usual maximum therapeutic dose is 200 to 450 milligrams daily, with up to a maximum of 900 milligrams per day. Okay, so on this slide, I'm going to run through what clozapine titration monitoring looks like over 14 days in clinical practice. As discussed on the previous slide, on day 0 baseline checks, we have News 2, which includes pulse, postural blood pressure, temperature, and then on B, we have mental state, weight, review, management of adverse effects, full blood count, CRP, troponin T, and at point C, we have weight, BMI, waist, plasma glucose, lipids, and LFTs. So beginning on day 1, first day of the dose, you're going to do a News 2, which is pulse, postural blood pressure, temperature before dose, and then between 30 minutes to 6 hours post-dose. But however, because it's day 1, we're also going to do it at 2 hours and 4 hours. So 2 hours, 4 hours, and 6 hours post-dose. On day 2, we're just going to do a News 30 minutes before the dose and then 6 hours post-dose. Depending on the titration regime, that could be done twice daily. The same for day 3. On day 4, it's a News, 30 minutes post-dose, 6 hours, 30 minutes pre-dose, 6 hours post-dose, and B, a mental state, weight, review, management of adverse effects, full blood count, CRP, troponin T. On day 5, we're going to do a full News, 30 minutes pre-dose, 6 hours post-dose, and we're going to check the results from day 4. On days 6 to 10, we're just going to do A, which is a full News, 30 minutes before the dose, 6 hours post-dose. On day 11, it's A, News 2, and weight, mental state, review, management of adverse effects, full blood count, CRP, troponin T. On day 12, we're going to check the results from day 11, and we're going to do a News, and then days 13 and 14, it's back to News, 30 minutes pre-dose and 6 hours post-dose. Over the next 5 slides, there won't be any further attached commentary. We're going to look at the National Early Warning Scores, and I'd like you to click on each attached YouTube video, which has a discrete video on how to complete each part of the news score via Public Health England. Thank you for taking part in this online training. I hope it's been relevant and useful. I'll be attaching references at a later date. Thanks a lot, Steve.